Assalamu alaikum. Let's discuss about juvenile idiopathic arthritis, one of the highest topic of musculoskeletal system. Before jumping into the subtype, first I would like to discuss about the juvenile idiopathic arthritis at a glance. Like, if you think about the epidemiology of JIA, age should be less than 16, more common in the girls, and family history of autoimmune disease. So, family history of autoimmune disease. Uh, if you think about the clinical feature of JIA, it may be multiple joint involved. So, if it is more than 5 joint involved, it called polyarticular. It may be less than 5 joint involved, which is oligoarticular, and symmetric arthritis for at least 6 weeks. So, symptoms for more than 6 weeks, and there may be systemic symptoms present or not. If we think about the treatment in a short, like you can give NSAID, you can give dimers, and you can give glucocorticoids, and as a complication, this is the part you have to remember. I will go through the detail when I will discuss about the subtype. If you remember it at a glance, like there may be joint erosion or deformity, there may be osteoporosis, very high yield osteoporosis, and there may be uveitis. Okay, in juvenile idiopathic arthritis, what are the lab findings? There may be elevated inflammatory marker, as it is arthritis, inflammation, itis. So elevated inflammatory marker, elevated ASR, and elevated CRP. There may be hyperferritinemia. Ferritin level would be high. There may be hyper gamma globulinemia. There may be hyperferritinemia. There may be hyper gamma globulinemia, and there may be thrombocytosis and anemia. There may be anemia and thrombocytosis. So these are the labs we can found in JIA. Okay, the most high yield chart of JIA is this: systemic JIA, polyarticular, and oligoarticular. Mainly these three types. And oligoarticular frequency is much more common than poly, than systemic. But systemic GIA is a classic. So age of onset is usually less than 18. Age of onset is usually less than 18. What are the clinical feature? Arthritis, one or more than one joint. So arthritis, one or more than one joint for more than 6 weeks. Arthritis, one or more than one joint for more than 6 weeks. There is quotidian fever for more than 2 weeks. What is quotidian fever? Quotidian fever is 1 to 2 spikes per day. The fever spike will 1 to 2 spikes per day. In quotidian fever, temperature is more than 39 degrees Celsius or more than 102 degrees Fahrenheit, often in the evening, and more than 1 to 2 spikes per day, often in the evening, for more than 2 weeks. For more than 2 weeks. They return to normal or below normal between spikes. So temperature will rise 1 to 2 spikes per day, and it is 102 degrees Fahrenheit, and it is often happening in the evening for more than 2 weeks, and they return to normal or below normal between these spikes. So arthritis, one or more than one joint, quotidian fever for more than 2 weeks. There is evanescent rash. Evanescent rash is salmon color macular rash. It is salmon color macular rash. Typically appears on the trunk and proximal extremities and accompanies fever spikes. The rash fades as the temperature returns to normal. Very, very classic. This rash fades as the temperature returns to normal, and patient often develops lymphadenopathy, hepatosplenomegaly, male-female ratio is equal. There may be other various form of serositis like pericarditis, pleuritis, peritonitis can occur, and systemic JIA is is a very classic. Okay, if systemic JIA, think in that way. If it should be less than 18, if age more than 16, and features looks like systemic GI, if age more than 16, it is referred as adult onset still disease. And we know that in adult onset still disease, there is hyperferritinemia. So systemic GI looks like systemic GI, but age more than 16, like age more than like age 20, features looks like systemic GI. Think and it may be referred as adult onset still disease. Okay, now polyarticular GIA. Polyarticular GIA, age of onset is age 2 to 5 or 10 to 14. Arthritis more than 5 or more than 5 joint may be complicated with uveitis. Polyarticular, oligoarticular may be complicated with uveitis. Polyarticular more than 5 joints. Oligoarticular is arthritis less than 5 joints. And in polyarticular arthritis is, we know that it is symmetrical like JIA, and the wrist, knee, ankles are most commonly affected. Wrist, knee, ankles are most commonly affected. And in oligoarticular, there is less than 5 joints within 6 months of the symptom onset may be asymmetric. It may be asymmetric. So oligoarticular may be asymmetric, and female has more propensity of happening than the male, and systemic symptoms are absent in poly and oligoarticular JIA. And we can diagnose. Differential diagnosis is acute rheumatic fever, but in acute rheumatic fever it has migratory polyarthritis and fever less than 6 weeks. But in systemic JIA, fever more than 6 weeks, or arthritis uh, more than 6 weeks. And why the fever pattern is why what type of fever pattern is seen in systemic GIA? Daily fever spikes, 1 to 2 spikes per day, and temperature is 102 or 39 degrees Fahrenheit. Temperature is 102 or 39 degrees Celsius, fever temperature often happening in the evening for more than 2 weeks. They return to normal and below normal between the spikes. Okay, how we can diagnose? We can do CBC. In CBC, there is hemoglobin is decreased. Hemoglobin is decreased as there is chronic inflammation. Platelet is increased as uh, platelet is increased. Leukocytes are increased. Can be normal in oligoarticular GI. So in CBC, platelets are increased. There may be thrombocytosis. Hemoglobin is decreased due to chronic inflammation and leukocytes are increased. They are inflammatory marker ESR, CRP is increased, but can be normal in oligoarticular GIA. Autoantibody in systemic GIA, ANA, and rheumatic factor are typically negative. In polyarticular ANA level is often positive in younger patients in associated with uveitis in oligoarticular. So in oligo and polyarticular ANA is positive, but in systemic GIA, ANA and rheumatic factor is negative. And X-ray show narrowing. If we do imaging, X-ray show narrowing and erosion. X-ray show bony erosion and diffuse uh, joint space narrowing, diffuse joint space narrowing. Ultrasonography detects synovitis, effusion. What are the differential the what are the DDs? There may be infectious arteria. There may be infectious arthritis, inflammatory or rheumatological disease, transient synovitis. There may be neoplasm, acute lymphoblastic leukemia, acute lymphoblastic leukemia. Okay, so the differential diagnosis is infectious arthritis, inflammatory or rheumatological arthritis like transient synovitis and neoplasm, acute lymphoblastic leukemia. There may be non-pharmacological management and pharmacological management, NSAID, glucocorticoid, disease-modifying anti-rheumatic drugs can be uh, given. And in systemic GIA, there are some complications, very, very, very high. In systemic JIA, there may be macrophage activation syndrome. Macrophage activation syndrome is a hemophagocytic syndrome characterized by unregulated activation of the macrophage and the lymphocyte that can occur at any time. Although these occurring in the first few weeks of the illness, patient often unremitting fever, rash, unlike intermittent fever and rash seen in systemic GIA. And in here, there is markedly elevated liver enzyme, hyperferritinemia. Patient require aggressive treatment of the underlying GIA, often including a course of high dose of glucocorticoid. And in there may be lung disease, chronic parenchymal lung disease, bialveolar proteinosis, and interstitial lung disease occurs in the GIA, and there may be abnormal growth. There may be abnormal growth due to prolonged glucocorticoid use. There may be abnormal growth. So these three complications these three complications: macrophage activation syndrome, lung disease, and abnormal growth due to chronic glucocorticoid use. And for polyarticular GIA, there may be TM arthritis, temporomandibular joint arthritis, and there may be uveitis. And in oligo There is TM, temporomandibular joint arthritis, and uveitis. Uveitis is a must know complication happens in JIA. So that is all. This is a brief discussion of juvenile idiopathic arthritis. Hope you enjoy.